Now we will start with the first session. Dr. Youssef. Thank you.
عطوفة نقيبنا دكتور زياد، بدنا نشكرك على ما تقدمت به الحقيقة، وانت يعني بتتكلم باسم الأردن، نقيب أطباء الأردن، الله يوفقك ويطول عمرك. واللي جبتها جين سمرفيل درستني شيء غول أنا كنت أسميها، كانت ترعبنا، درستني في نشر الهارت هوسبيتال، فعلمتنا congenital heart disease، وجوزها قوية، ما هو في ستات قويات ترى مرات، دير بالك يعني. نفتتح جلستنا اليوم، دكتور وائل لسه ما وصل، فنفتتح الجلسة اليوم في المتحدث الأول، وما بده تقديم الدكتور هادي أبو هنطش. He needs no further introduction الدكتور هادي، وأستاذ أمراض القلب والتداخلي، ويعني ما في شيء أقوله عنك هادي، زميل وعزيز وغالي. تفضل رايح يحكي keynote lecture left main PCI where are we now in 2024. تفضل.
الدكتور رائد العوايشة والدكتور أيمن حمدان. أيمن
الله يصبحكم بالخير جميعا. أول شيء thank you دكتور يوسف، أنا دائما تخجل تواضعي when you introduce me. Thank you very much. Let me just kick it started and go quickly so that I finish by 15 minutes allotted to me. Left main intervention remains one of the complex interventions. Irrespective of how you look at it, that's how it's enlisted. It's a complex PCI. Whether it's a shaft, whether it's an osteal, it is a complex PCI. Now, the most important part for us interventionists is to find a way that our procedure makes a difference. We're not there just to open a pipe. We want to know whether with our techniques we can make a difference in terms of outcome, whether it's short or long-term outcome. Let me share some of my cases with you from my library I have. This is a left main shaft case, which is very unusual. You will encounter it in 15% of left main stenosis. You can appreciate the shaft stenosis there. And there is a right coronary which is filling retrogradely and some disease in the proximal circle. So it's very rare that you encounter an isolated left main. It's hardly 4 to 6% of what we see. So most of the cases of left main are combined with other disease. So what did I do with this patient? Simple balloon angioplasty, one stent to the left main from ostium just before the bifurcation, and patient did well, no problem with the procedure. Ostial left main is not common either, but it can happen in 23% of our cases of left main stenosis. This is a patient of mine which was really very sick and bad failure. She's intubated, you can see the tube, and I cath her and she had ostial severe right coronary stenosis and also stenosis in the ostium of the left main. So what did I do? I did the ostial left main, beautiful results, did the right, beautiful results, patient recovered very well. We don't encounter those very commonly. What is more common in 2/3 of the cases of left main that we have bifurcation lesions. This is one case of mine. You can see it's a 100 left main lesion. There's some disease in the proximal LAD, and what you can see here that this is a typical patient for provisional stenting, which I did. The wire was protecting the circ. Provisional went fine with excellent results. This is a 010 left main. Please remember that ostial LAD is a left main. Ostial circ is a left main. It's not an isolated disease. So this is a 010 left main case, which I did the provisionally too, with one stent protecting the circ, and that worked out very well. This is another patient who has a 110 left main case. Again, did angioplasty, provisional stenting, and with the protection of the circ, went very well. Why am I showing all of this? I'm not in a showcase type of trying to convince you that I can do left main. It's because everything we do in the left main, most of it in that with one stent provisional type. This is an unlucky patient who had an aortic valve replacement. He could not afford TAVR. And at that time, he had a moderate stenosis in his left main. My colleague surgeon did not feel that he needs to be revascularized. A year later, he came to me with acute coronary syndrome. You can see how little the left main is compared to the circ and the LAD. So it's a very diffuse left main, stopping short of the ostium of both great branches. What I did again, I tried the provisional, protected the circ. Unfortunately, the circ came down, and I had to do a tap technique, 2 stents, and you can appreciate the result on the right side. It worked very well. Now, we interventionists think we can do everything. Yes, we can do everything. But what is best for patients? Left main in all the guidelines remains a class 1A recommendation for coronary artery bypass surgery. Whether we like it or not, interventionists, that's the way it is. However, that's mainly also to improve symptoms in patients with symptomatic ischemic heart disease. By the Americans say SIHD, the Europeans say chronic coronary syndrome. You look at this, if in selected patients with those symptomatic patients with the chronic coronary syndrome, you can do a PCI if you are sure your PCI revascularization is equivalent to CABG. So we have to do it as good, if not better, as the surgeon. And even with that, it's a class 2A. It's not a class 1. Diabetics always, we talk about them. Diabetics with diffuse disease, I don't think we have to argue about that. Diffuse coronary disease with left main and diabetic, they need bypass. When would you do that for diabetic patients, left main and other vessel disease? Well, if the complexity of the lesions is relatively simple, you can do it. And that's not common in diabetic patients. Even with that, if you do left main and other vessels in the diabetic, it's a class 2B. So it's not really highly recommended. Now, when is PCI is the gold standard? For us interventionists, ST elevation myocardial infarction, left main is the culprit. What do? You do PCI. No surgeon will take him to an emergency bypass. What we do also, when patients have very poor targets for Lima, REMA, 7S grafts, definitely we can help them better with our PCI. And of course, if there's a very advanced, prohibitive type of comorbidity, which makes CABG highly risky. So the big question is, should I do 1 or 2 stents for PCI of the left main? Nobody would argue that for the shaft, for the ostial and the left main, 1 stent is enough. You don't have to land it in any of the branches. But remember, everything you do in the left main, all the guidelines tell you what? They tell you, please use IVAS guidance, pre and post, of course, if you can. Now, when do you do 2 stent strategies? If there is a bifurcation, which involves 1 or 2 of the major branches, you can consider 2 stent techniques. But what we do most of the time, we do provisional, protect the other branch, do a tap technique if you have to get the branch if it's compromised. When you look at the literature, so what kind of stent technique you have to do for bifurcation? We always argue about it, right? Well, in the Excel trial, you're all aware of it, which was published in 2018, and it looked at left main versus CABG. We all know about it. I'm not going to dwell on the study itself. What did they find? In the Excel study, the early outcomes of 1 stent or 2 stent techniques were exactly the same. They did not differ. At the 3-year follow-up, there was a divergence of the curve, which is better for a provisional compared for two-stent techniques. In that particular study, 65% of the cases were managed by a provisional technique. So common is common wherever you go, even in randomized studies. The two-stent technique which was used was TAP. So it was a T-stent with minimal protrusion, 50% of the case. So in 2018, at that time, DK crush colot was not the most commonly used for those particular patients. When you look at the curve here, you look at death, stroke, MI, on the right side, death, stroke, MI, and you add to that ischemia-driven revascularization. Provisional stenting, which is the solid line, was a lot better than two-stent technique. However, look in the red what I wrote. This is only true if it's confined to patients without major involvement of both side branches. So it enlightened us, the Excel trial, إنه مش كل مريض بده one stent ولا كل مريض بده two stents. So which are the ones which need two stents up front strategy? The definition trial in 2021 enlightened the community on which of which is the complex one. If the branch, like if you're doing left main bifurcation with ostial LAD, and the circ has a stenosis above 70% or equal, and the length of the stenosis was more than 10 millimeter or equal, those patients will need an upfront two-stent techniques. That's how the definition, and most of us agree upon definition of two-stent upfront strategy in which of which patients. The definition 2 trial came to answer a question. In those patients with the complex lesions like this, two-stent strategy, which technique is better? What did they find? They found that two-stent technique upfront compared to provisional was definitely better in target lesion failure, target lesion MI, and target lesion revascularization. So in the blue bar here. So definitely upfront two-stent strategy. In the complex lesions, do it. In the other lesions, you can manage with provisional stenting. In the definition 2 trial, 78% had a DK crush. I know not a lot of us do it, but that's how the better data came out. 28% of those patients in definition 2 had distal lift main, so you can apply the data to distal lift main. The European Bifurcation Club published an impact of technique paper in 2023. Now, what did they teach us? Like the others, it might not make a difference to do 1 or 2 stents. However, they told us important lessons. Jailed wire is associated with successful jailed vessel rewiring. I know some of my colleagues, they are in the habit, they put a wire in the circ, wire in the left main towards the LAD, before putting the stent in the left main towards the LAD, they pull the circ wire. Please don't do that. It's called jailed wire. It's not a protecting wire. Keep it jailed. Side vessel preparation is a no. Do not side vessel prepare your patient unless you are ready to do a two-stent technique. It's because there is an increased side vessel dissection requiring stenting, but proximal optimization technique definitely reduces the need of side vessel intervention and makes it easier to recross the wire with the side to the side vessel. Kissing balloon techniques, you do it with non-compliant balloons. That's important. It's not compliant. Do it with non-compliant balloons only. Of course, imaging, you cannot just underestimate how important it is. Distal left main calcified with IVUS, look how heavy the calcification is. It's a 111 lesion. It was prepared with angioplasty, 2-wire technique, circle LAD, IVL was used, beautiful DK crush technique, beautiful result. Look at the IVUS telling you how good the opposition is, and the minimal stent area was perfect. So procedure-guided IVUS is so important. Why? It first tells you how to prepare the lesion. It tells you if there is an intermediate lesion versus significant, if it's less than 6 millimeters square. And it tells you which dissection you have distal stent has to be fixed, which malopposition needs to be fixed, and which under-expansion needs to be fixed, which is important. You cannot just depend on the angiogram to answer these. The American College of Cardiology made it so clear that intravascular imaging in left main PCI should be routine. It should be routine, like what you do for all interventions. Now, it's still 2A recommendation, but it's still better than nothing for sure. FFR, definitely you can use it for intermediate lesions. It's hard to interrogate an ostial left main, of course, with IFR or FFR. However, one of the values of the FFR, if you have a compromised circ when you're doing left main to the LAD stenting, you can do an FFR, and if the FFR is positive, you do stent with TAP technique. If it's not, then you don't have to do it, and you don't have to touch it. But we do not have studies to tell us that this approach will give you a better outcome. But that's what we do. We do it every day. So, what is my take-home messages for left main in 2024? Routine adoption of intracoronary imaging is strongly suggested to improve procedural results and long-term outcomes. As I started my talk, we're not there to open a vessel, to open a pipe. You want better outcome. You want better outcome, you have to use intravascular imaging. The vast majority of left main PCIs can be performed using provisional single stent strategy. Please remember that. For a dedicated two-stent strategy, studies after studies have shown that DK crush is probably the way to go, and it's superior to clot if some of you use clot. Definitely TAB, TV, and reverse TAB is not the most popular to be used. For unplanned two-stent strategy, if you have a compromised circ after left main to the LAD, the best way is to end it with a TAB technique at that time. And please remember, jailed wires, put NC balloons for KISS, avoiding a branch B dilatation and provisional approach is the way to go. Thank you very much. الدسكشن بعدين. شكرا أبو ضايق.
Hadi, two thanks. First, for sticking your time exactly. And second, it was an elegant, excellent talk. And third, we leave the questions till the end of the session for the discussion and QA segment. Now I'll hand microphone to Dr. Rai.
Most welcome everybody, and I hope to go fast. Thank you to Hadi for restricted time. And now we go directly to the second speaker, Dr. Ahmed Magdy. He's well-known everywhere, and to Jordan, he's most welcome always in our PCI MENA. Professor Magdy, he will talk to us about high-risk left main intervention. Thank you very much. Please.
Good morning, everybody. I am happy to represent Egypt among my friends, as well as the Sky. Also, I am representing the Sky. Thank you, Professor Mahmoud and Professor Riyad, for inviting me. So I will. This is the Ischemia Club, which is the Egyptian Board of Intervention faculty. This is the European Bifurcation Club. We are sharing their experience since almost 10 years. And now we have the Middle East Bifurcation Club. So I will show cases with educational lessons, but let's define what is the high risk left main intervention. If you have patient comorbidities, heart failure, diabetes, advanced age, acute coronary syndrome, or complex coronary disease like multivessel disease, it's distal 111, or there is a hemodynamic compromise. Left main PCI remains a challenge for intervention cardiologists, always high risk. And now we have the term of protected PCI. If you know that this is a challenging left main case, and there is hemodynamic embarrassment, and there is all this and complex coronary anatomy, then there is a definition for the protected PCI and for the chip. you have to calculate the syntax score, and this had been developed into a clinical syntax score, the residual syntax score, cabbage syntax score. All these scores help to identify who is high risk. So this is a 75 years old Saudian. He traveled to Egypt, and he had acute coronary syndrome. At night, there was extensive anterior infarction. He was hypotensive. So they called us, and apparently there is total occlusion of the LAD and subtotal occlusion of the CX. And so they gave him tirofiban, and they transferred him to us. When he reached our hospital, he was he was shocked, and the CX started to appear. And so we did a two-stent technique for this patient. It was a TAP technique, and he was saved. Apparently, the center where he had the infarction, they don't have the facility of doing complex PCI, or they don't have standby surgery. And so this patient was transferred to us. And the most important thing in CHOC and in high-risk cases, of course, in the setting of MI, surgery may not be preferred because of very high risk. However, in this case, we were successful to open the arteries, and he survived. You don't need to do at night a very complex procedure. Try to make the procedure which you are familiar with. Here the angle was wide, and so we didn't need to do deep crash. We just did by T-tap technique, and we wired all the branches, and it was successful. This is a doctor. He's Sudanese. He had acute cardiac event, arrested in his way, and luckily enough, there was a doctor beside him, and so they resuscitated him, and then he drove his car to the emergency room, and they found that he has MI. They did angio for him, and they advised him for surgery, but he refused, and he waited until he was stabilized, and then he came to us. Apparently, there is a very tight ostial left main, as well as multi-vessel disease. He refused surgery, and he's 78. And we were able to do the LAD, the left main. Now we are not in the setting of acute MI, and so you don't do the culprit first, which was the right coronary. So we started with the worst, which is the left main. There was great damping, and as you observe, we are keeping the guiding cath outside the cusp because of damping pressure. And you have to identify with the start. I have IVUS images, but I didn't include in the video. So we did the circumflex, the LAD, and the CX did not need anything, as my colleague Dr. Hadi has explained. It was free, and so we did the LAD, starting it's very important to identify the start of the lesion in the left main ostium, and we cover the whole left main and the LAD as well, and then we did the right, and he survived. This is the right coronary. This is, of course, there is a high syntax score, and this is the final result of the patient. And this was done 2 years ago, and he's doing very well. This is a patient I did 20 years ago. He came to me. I was in the Heart Institute. He had cabbage 10 years earlier, severely hypotensive, severe chest pain. The only remaining vessel was the ostium of the circumflex. By that time, it was the beginning of the drug stents, and so we did just direct stent for that circumflex. Ejection fraction was very poor. All the grafts were occluded, and we did that, and he survived. This was 20 years ago. And then last month, I had a patient, 72 years old. He's not diabetic. He had cabbage also 10 years earlier. And over the last 6 months, he complained of progressive dyspnea, repeatedly admitted with heart failure, non-STEMI, some of the events. He did not respond to maximal anti-failure treatment. And geography was showing left main distal, total occlusion, followed by LED that is totally occluded, but it has a patent lemma, and the circumflex is totally occluded. The right is non-dominant, and so we thought that the circumflex is the result of, is a cause of this scenario. He had his son in Chicago, and so they discussed the angio, and then they found that PCI would be very high risk, and surgery is not possible. And so let's observe and see what happens. And so because of 2 levels of obstruction in the distal left main and then the CX, and there's too much calcification, and the very bad angle between the CX and left main, and he's in heart failure. So this was the angio. So we are happy that the LED is already having a patent graft, and so we prepared atherectomy, and we prepared specialty balloons. We were able to pass the wire, and luckily enough, we found that this wire opened all the CX lesion, and also the distal total occlusion in the CX. It was a pilot 200. And then this part, which is calcified, we tried to avoid root ablation in this part, so we used a Wolverine balloon, which is the kind of cutting balloons to cut the calcium, and then we waited for to see how it looks like. We were afraid to pass a stent or balloons, and we were happy that all the CX was opened, and then we passed just a onyx stent that covered only the proximal part. Apparently, the distal part didn't need anything. We stented that artery, and the patient survived. Heart failure improved, angina disappeared, and the condition was satisfactory. Of course, we did post dilatation by NSC balloons. Maybe we used a balloon 4.25 for the left main and proximal LED, proximal CX, and the patient was solved. This is a 70 years old diabetic. She had PCI, LED, and circumflex 10 years earlier. Severe progressive angina associated with stigma depression for 3 millimeters. Ejection fraction is compromised. Angio, short left main, distal left main lesion, ostial lead and CX, patent stents in the LED and circumflex. She came like an emergency at night, so we jumped and we did for her a mini crush for the distal left main. It is a very short and there is slight lesion, and she's in non-STEMI. We did a mini crush. Okay. So what I just need to say that this patient came after 3 months with in-stent restenosis in the LED only, and so at night my fellows, they did just a balloon, and we as expected after another 3 months she had severe in-stent restenosis, and so we prepared a DCB for this lesion and protected the CX, and we dilated the circumflex DCB non-compliant balloons, and the patient did well after that. So thank you for invitation, and thank you for listening to me. Okay.
Thank you. Thank you, Dr. Ahmed. With no further delay, Dr. Hussam Suradi, he's our friend from USA. He's Jordanian from USA. He will talk to us about the left main PCI again. This is left main, so everything about left main is present here. Go ahead.
Thank you, Dr. Raed. Good morning, everyone. First of all, I would like to thank the organizing committee for the invitation to be here. It's really great to be back in my home country and reconnect with a lot of friends and colleagues. So we're going to stick within the theme of left main PCI, and this is a great segue. Dr. Hadi and Dr. Ahmed gave fantastic talks about left main intervention that really makes my talk much easier. So I'm going to share a case that we did within the past year for a 91-year-old patient who had a past medical history of hypertension, stroke, seizure, who was initially presented to an outside hospital with altered mental status and chest pain. And he was admitted with non-ST elevation MI with elevated troponin. And this is his diagnostic angiogram in the outside hospital. So as you can see, there's really a critical distal left main stenosis that involves both the ostial LAD and the ostial circ. The proximal circ is also subtotally occluded. There's a really good size first OM coming out there. And there's at least a TIMI2, TIMI1 flow within the LAD. And this is the right coronary artery, which shows basically distal RCA disease and severe disease within the proximal PDA. So at that point, as I said, this was in a community hospital. A balloon pump was placed in, and the patient was transferred to our institution at Rush Medical Center in Chicago. So we do have a heart team approach in assessing every patient with complex coronary disease, regardless of the age. 91, we all agree that surgery is not the best approach. However, we decided that the PCI is the best approach for this patient, and this is the initial echo. As you can see, EF is relatively preserved, maybe mildly reduced, low normal, with anterior wall motion abnormalities. So our plan was to proceed with high-risk PCI. So as we are planning this procedure, several considerations that we were thinking about is, do we need to use hemodynamic support in these cases? Are we going to need any kind of calcium modification tools to treat the left main lesion? And are we going to end up needing a 1 or 2 stent technique? So as a standard technique in our institution, we do tend to get invasive hemodynamics in all patients to assess the need for mechanical circulatory support need during the procedure. Remember, this patient has a balloon pump, so we did a right heart cath, and these are the initial numbers. Not terribly bad. The cardiac index mildly reduced, 2.3. However, due to the advanced age of this patient, the critical nature of his lesions, the very high likelihood that we're going to need an atherectomy is going to be a long procedure, and he's not going to have a surgical backup. We decided to use Impella support for this intervention. Again, it's a luxury tool that we have access to. It's available, so it's easy for us to make a decision of pulling it out and using it. So here you see the Impella sheath. This is a 14 French femoral sheath. And what we use is we can use the same sheath to advance a second transfemoral sheath for our PCI. So here you see the big 14 French sheath, and within the hub of this sheath we can puncture and put up to 7 French sheath in that sheath. So really we just need single access for these interventions. We don't need a second access. And for those who don't know the Impella device, this is the Impella device. It's sitting within the ventricle, and what it does, it basically pulls blood out from the ventricle and pumps it into the aorta, unloading the ventricle. And these are the initial guide shots. Again, you see the critical lesion in the left main. Relatively, the LAD flows slightly better compared to the initial. Remember, it was like TIMI1 flow. And maybe we're thinking it could be related to the Impella. You know, the Impella, it unloads the ventricle, so the coronary perfusion improves, and this is why you see it on angiography, a better flow. And here the spider view, again, kind of really tricky lesion. It's eccentric. We thought like wiring is gonna be a challenge. And one thing that you're gonna think about, like once you have a wire in, very likely flow is gonna get interrupted. And this is the beauty of having the Impella support. It can give you some time and some, maybe peace of mind that the patient will be well supported during any hemodynamic compromise. And as we expected, really wiring that lesion, the LAD, was very, very difficult. We have a wire now in the OM, as you can see, but we tried a polymer jacketed wire, tapered tip wire, a Gaia tube, could not really wire that LAD. Then we ended up using a dual lumen microcatheter, twin pass catheter. So we advanced this twin pass over the OM wire, and using the second distal port, proximal port on the microcatheter, we used the fielder XT with a polymer jacketed wire to try to navigate that lesion. So here you see this is the microcatheter. You see the flow is already getting worse. There's staining in the ventricle, and now we were able to successfully advance the wire into the LED. And for this case, given the really, the way it looked, the heavy calcification, we decided from the get-go, we're going to use rotational atherectomy. We use the 175. It's a large left main and a large prox LED. So we use the 175 Rota Pro. We did really several drills there. We get with good results. And this is the flow after atherectomy. Now the decision is, what's our bifurcation PCI technique? Is this going to be a provisional, or is it going to be a two-stent technique? There's really, in my opinion, you can maybe get away with a provisional, but there was involvement in the proximal circ. Beyond that OM, you see that there is the mid circ or the proximal circ is subtotally occluded. It's almost already gone, and it's really not a big vessel. He's a 91-year-old. I decided really to preserve that big OM along with the left main and the LED. And our decision was to go with a two-stent technique. So the two techniques that you can think of, DK crush, culotte, and maybe tap. In this case, we decided to use a DK crush due to the discrepancy between the circ and the LED vessels. And again, it's really a comfort. Whatever technique you're comfortable with, you can use. Prior to proceeding with stenting, we did intravascular ultrasound, just as Dr. Hadi mentioned. We do IVUS for all our left main. It is really associated with a better outcome. You can see the circumferential calcification, 360-degree calcium within the proximal LED, all the way extending to the left main. And the other reason why we use IVUS is to have really proper sizing of the vessel. So the left main measured on average about 4.5 millimeter, and the proximal LED about between 3.6, 3.75 millimeter vessel. So we proceeded with balloon pre-dilatation. We ballooned the LED and the circumflux with good expansion. And then we started our DK crush bifurcation steps. There are a lot of steps into this. So now we have two wires in the LED and the circ. We started by stenting from the OM all the way into the left main. We used a 275 by 22 Onyx. This was deployed. Before you pull the wire or you crush the stent, it's very important you take an angiogram, make sure there's no distal dissection within the OM, so that if you need to put another stent before crushing, this is the time you can do it. The wire is then removed from the OM, and we already have a balloon parked in the left main. Usually it's a 1-to-1 size balloon, and once we're in position, the stent is crushed. And then the first casing balloon is performed. Again, I usually use 1-to-1 NC balloon, both in the ostial LED and the ostial circ. Really, what was interesting that I found, like, we were, again, in retrospect, we're lucky that we were using hemodynamic support. You see loss of pulsatility during the kissing balloon inflation. And you see that the mean arterial pressure was still well maintained due to the Impella hemodynamic support. So this was one of the nice examples where, you thank God that you really used Impella in this case. Then we proceeded with stenting the LED all the way into the ostial left main. So this is a 3.5 by 38 Onyx, all the way from the mid to the ostial left main. We take in several different projections. And this is the stent being deployed. And prior to wiring the circ again, we do proximal optimization technique to expand the left main stent. This makes wiring to the circ is easier and avoids the wire to go outside the stent struts. So after wiring, we did our second kiss. Again, 2 NC balloons in the across the LED, left main, as well as the circ. And then again, we do a repot with a 4.5 by 8 NC balloon. And this is the final result, TIMI3 flow within the LED, within that OM. Again, that mid-circ was already gone, and I didn't really feel the need of going after it. And always finish with doing IVUS to make sure that the stent is well opposed and well expanded. We had a minimal stent area of 16 millimeter. Anything more than 10, the left main is really associated with better outcome. And before deciding to remove the impella at the end of the case, we do hemodynamic assessment, which looked good. And this is the echo. Really, the next day you see remarkable improvement in the wall motion normality and the LV function. Thank you very much.
Nice cases from all the speakers. Can we open the floor for discussion, please? And if the speakers join us here, I think we have space for the speakers. If anybody has any question for any of the speakers, most welcome. Dr. Montasser.
We are running late, so we'll keep the discussion for 10 minutes. Because at 11 we are having an important virtual lecture from Italy. So 10 minutes instead of 20
Thank you so
minutes.
much for interesting session. My question to Dr. Hadi. Assalamu alaikum, Dr. Hadi. That was a nice presentation. Recently in the Euro PCR in Paris, there was some session about pure ostial circumflex and what to do for that. And I like the statement that you mentioned that any pure LAD or LCX ostial lesion is a left main, which is Medina 010 or 001. And I totally agree with that. My own practice is to extend the stent whenever I decide to the left main. But because there was like a study that only when IVUSing those patients, only 6% have a pure. Otherwise, there is extension proximally to the left main. So you think there is still a room for stenting only the ostial in our practice, or you support that all these pure ostial or circumflex, if decision to stent, should be extended to the left main? And if you have also a comment about the DCB rule in these cases. Thank you so much.
As I mentioned, ostial left LAD or ostial circ is considered part of the left main, and the proximal LAD before the septal, of course. As you mentioned, angiography is not going to tell you the extent of the disease. I mean, you can see it on the angiogram, like it's ostial LAD, you put the IVUS in, and it's a diffuse disease involving the LAD, involving the circ, so that will change your strategy. So I think the answer to your question, I was not in that session particularly, which you mentioned. I think if you do intravascular imaging, that will guide you through what to do next for your patient. Should you restrict yourself to the ostial, but one thing which I do not like is trying your best to not to touch the distal left main with your stent. I mean, don't try to do that. It's just a waste of time. You have to protrude, whether you like it or not. You have to protrude. And the protruding part of the stent in the left main is actually safer than missing the ostium anyways. So I would depend on the intravascular imaging to guide me through the cases. Yeah. DCB. DCB, the proponent of DCB is coming up next, Antonio Colombo.
Yeah, he will answer this question, I think, at
Sorry?
the Bedford.
Yeah, he will answer that question.
He will answer
actually,
this, so we'll talk about DCB thoroughly. Dr. Hussam, do you see it safe to use rotablator in left main? How safe is that? And the second point is the mechanical supporting device and how you compromise between the access complication and the importance of supporting.
Great questions. In terms of using atherectomy for left main, I think it is safer to use it if it's needed rather than not to use it. You really need to modify the calcium in the left main to get the best results and the best outcome of stent apposition and stent expansion, which we all know is associated with better outcomes. If I have, little doubt that there's going to be significant calcium, I go with atherectomy from the get-go. Sometimes I do IVUS prior to that, if I have questionable, like the degree of calcium, the severity, how much of an angle is it, so that I can decide, do I do balloon angioplasty versus atherectomy. But no doubt, really, I think the left main.
Do you prefer per size in left main to avoid bias?
Yeah, so I generally, I use at least 0.4 to 0.5 of the vessel size. So, most left mains are not less than 4 or 5. So in general, you can really use up to 2 if you really needed to.
Yeah, the big bar.
Yeah, so in general, I rarely go above 175. Most of the time, 1.5, you get the job done. But yeah, I mean, it's really better, makes the procedure faster and safer, in my opinion, rather than just depend on balloon angioplasty, shockwave, all of these things, and risk suboptimal result. As far as your second question, how do we balance between using MCS, vascular access, vascular issues? Great question. We usually, know the vascular anatomy ahead of time. We usually do femoral angiogram before we put the sheath in. If it's a small vessel, we think it's going to be, a complicated case. We usually avoid it. In certain cases, we use alternative access, going subclavian, putting an impella sheath in the subclavian artery. You can do that percutaneously. You can perclose it. We've done that safely as well. But most of the time, these cases, we think we're going to take the impella at the end of the case. We're not going to, it's not going to be prolonged ischemic limb in there. So, yeah, we tend to be careful about which cases we're going to use.
Thank you, sir. Any further question? Okay, go ahead. I will take you. We cannot hear you. Can you turn on the mic, please? Yeah. The mic, girls. Can you?
Okay, thank you very much. So my question to Dr. Hussam, do you think the rotational atherectomy or IVL more preferable approach or strategy in case of the distal main stem? As we know, if you follow the trials, follow the studies, the left main stem lesions characteristically deemed circumferential, and you can protect both wires by the IVL. So let me know your experience with rotational atherectomy or IVL strategy in case of distal left main. The second, my question to the panelists or speakers, did you perform final kissing balloon inflation routinely in case of the provisional stenting in the left main stem without jeopardization of the ostial side branch? Dr. Hussam.
The second question is not clear. Can you clarify?
So my first question.
Second question.
The second question is the routinely perform final kissing balloon inflation in case of the provisional strategy in the left main stem bifurcation when we are going to see there is no any jeopardization of the ostial side branch.
You mean post-stenting dilatation to the side branch?
Yeah.
Thank you.
Yeah, I mean, so as you know, when we do rotational or orbital atherectomy, you need to have only one wire in the vessel. You have to lose the other wire. So in general, if I think one of the side branches, which is the less critical, is easy to wire, I usually just do the worst one with atherectomy, and I can switch them around. And most of the time you can rewire easily. In cases where it's really difficult to wire, what I've done is I can keep a microcatheter over one wire to protect it. We use usually fine cross. It's the smallest microcatheter diameter. So basically, if for example, you're doing atherectomy for the LAD, you can keep the wire in the circ to protect it, keep a fine cross or microcatheter, and I usually go with 8 French guys in these cases, and then you can do the atherectomy over the LAD wire. And while you're doing the atherectomy, generally we tend to change the position of the microcatheter so you don't abrade the same location and risk of injury or tearing the microcatheter.
Hussam, the question is IVL.
IVL or rotational atherectomy in distal left main.
Data comparing both, you mean, using IV, when do I use it?
Do you use it or you don't use it? Do you have any
we've used
experience
it. Again, I really like atherectomy, and again, I don't think there's a head-to-head comparison, IVL to atherectomy. If I think like it's going to be relatively, not circumferential calcium, I'm going to get good result with IVL, I usually do it. If you're using hemodynamic support, you don't mind having balloon inflated longer time, you can use IVL. It's really a preference. I don't think there's data saying, which one is better.
There is a data with Rainbow trial waiting the result. It's directed to a trial between the rotational atherectomy versus IVL. But my points in case of the distal left main, characteristically almost always the atheroma and the calcification is edema and circumferential. That's why IVL, it's more preferable approach over rotational atherectomy, especially in patients with acute coronary syndrome. So let me know the answer of the second question, please.
After you stent and you decide
the professional stenting, yeah.
And you find out the ostium of the left circ is clean and there is no black shift.
No black shift, no carina shifts.
Exactly. There is no need to open the struts.
Okay.
Yeah, I just wanted to comment on this because I think the more we do our things in a routine fashion, the less headache we get from left main. When you do provisional and the side branch is not compromised, there is no need at all to do kissing balloons.
Yes.
At all. This is one. The other common question which is always asked, I do provisional, lift main to the LAD. Should I open the strut towards the circ if the circ is looking good? The answer is no. Absolutely, there is no need to do it. So
okay.
Yeah.
So let me.
And
sorry.
not destruct them.
Sorry.
It is better to keep the struts intact and the stent not pushed from the other side when you open it. So you compromise the stent and the opposition of the stent from the other side. So it is better not to open the struts. This is the expert opinion. There is no study about it, but this is the expert's opinion.
So let me discuss briefly about my experience. I'm talking with the pioneer and the bifurcational club in the Europe. In any case of the bifurcational left meniscum, even a left meniscum lesion, final kissing balloon inflation is routinely recommended when there is evidence of the jeopardization of the ostial branch. When there is no any jeopardization of the ostial side branch, whether to do it or not, this primarily depends on the IVAS result. IVAS run show if there is any metal across the ostial side branch or if there is any narrow opening of the ostial side branch, very preferable to go by final kissing balloon inflation. Otherwise, there is no indication. If you don't have IVAS in your cath lab, routinely should we go for the final kissing balloon inflation even without jeopardization, especially when we're dealing with angina creating vessel or vessel size more than 2.5. And thank you very much.
Once we start talking about the left main, we need IVAS, and IVAS is guiding a lot of decisions like this decision. I think by this nice discussion, we are going to close this session. Thank you very much for attending. And we go to the second session. Breakfast? Oh, we have breakfast. We have break time for how long? Okay. 11 will come back.